Welcome. Today we're going to speak about mental health. By the time you finish this session, you should be able to speak comfortably about the burden of mental disorders, who is affected by that burden, the key risk factors for mental disorders, the health, social, and economic consequences of them, and selected measures that can be taken to address mental disorders. Let's start with two vignettes to illustrate the significance of these problems. Rachel is a 17-year-old girl in Ethiopia. Rachel is in her last year of secondary school. Lately, Rachel's been feeling very sad and having difficulty overcoming that feeling. Some days, Rachel doesn't want to get out of bed, leave her room, or go to school. She also cries a lot. Rachel is one of millions of people in the world who suffer from depression. Sam is a 35-year-old man in England. Sam worries a lot. From time to time, Sam worries so much that his heart beats fast, he gets sweated up, and he feels like he can't breathe. Sam is one of many millions of people in the world who suffer from an anxiety disorder. With these comments in mind, let's explore further some of the specific disorders we'll discuss today. One of the major categories of non-communicable diseases in the global burden of disease studies is mental and substance use disorders. This category includes a number of mental disorders, such as unipolar depressive disorders, anxiety disorders, bipolar affective disorder, and schizophrenia. The category also includes substance use disorders, such as alcohol use disorders and drug use disorders. In addition, it includes some behavioral disorders, such as conduct and eating disorders. Together, these disorders are very important to the burden of disease, causing about 7% of all DALYs in low and middle-income countries in 2013. Covering a wide range of such disorders, however, is beyond this session, so we are only going to cover here selected mental disorders. Now, 4 of them contribute the largest share to the burden of mental disorders. These are unipolar depressive disorders, which we'll refer to here as depression, schizophrenia, anxiety disorders, and bipolar disorder. Let's look at a graphic that briefly defines these disorders. Bipolar disorder is a serious mood disorder characterized by swings of mania and depression. Depression is a mental state characterized by feelings of sadness, loneliness, despair, low self-esteem, and self-reproach. Panic disorder is an anxiety disorder characterized by attacks of acute, intense anxiety. And schizophrenia is a mental illness, the main symptoms of which are hallucinations, delusions, and changes in outlook and personality. Let's now talk further about the burden of disease. The first thing I want to highlight is that the burden of mental health disorders is large, it's underestimated, and in most countries it's also very much underappreciated. Let's look first at the burden of these disorders globally for 2013 for both men and women and all ages. And let's, if we might, put the cursor over here, and we'll see that for both sexes, all ages in 2013, looking at disability-adjusted life years, for the world as a whole, depressive disorders constituted about 2.5% of all those DALYs. Anxiety, about 1%, schizophrenia, about 0.64%, and bipolar disorders, about 0.4%. And now let's look at how these figures would look if we shift to examining only the low and middle income countries. And here what we see is depression constitutes about 2.4% of all DALYs, anxiety about 0.9%, schizophrenia about 0.4%, and bipolar disorders about 0.4% as well. Now, It's important to understand that this burden of these 4 mental disorders in low and middle income countries in 2013 was greater than the burden associated with diarrhea, HIV, tuberculosis, or malaria. Let's now look at how the burden of these disorders varies between men and women. Let's start with a global look. And let's start with females, if we might. And here we see, when we're looking for 2013 for females of all ages at disability-adjusted life years, or DALYs, depressive disorders constituted almost 3.4% of all DALYs. Anxiety disorders about 1.4, schizophrenia about 0.7, and bipolar disorder about 0.5. Now let's take a look at men globally. And here we see, in fact, quite obviously, that globally, the burden of these disorders is higher for women than it is for men. For men that year, it was about 1.8 for depressive disorders, 0.6 for anxiety disorders, 0.6 for schizophrenia, and 0.3 for bipolar disorders. Now let's take a look at the same graphic, but examine men in low and middle income countries. And here we see that for men in low and middle income countries in 2013, about 1.7% of the disability-adjusted life years could be attributed to depressive disorders, about 0.6 to anxiety disorders, about 0.6 to schizophrenia, and about 0.3 to bipolar disorder. Now when we look at women, females in low and middle income countries, we'll see the boxes expand because the burden of disease and disability-adjusted life years for them is greater than it is for men. In fact, what we see is for women, depressive disorders were about 3.2% of total DALYs, anxiety about 1.3, schizophrenia about 0.7, and bipolar disorder about 0.5. Now, one reason for the large burden of these conditions is the substantial number of people who suffer from mental disorders. Another is that mental disorders often start at relatively young ages. They can go on for a very long time. They are sometimes not cured, and they therefore produce large amounts of disability. There is some mortality associated with these conditions, usually associated with suicide. But it's exceptionally important to think of them not just in terms of deaths that might be attributed to them, but really to disability and to the disability-adjusted life years associated with them. The World Health Organization carried out projections in 2008 and looked at how the burden of disease might move between then and 2030. And these projections suggested that these mental disorders would become increasingly important in all country income groups, in all regions of the world, and also suggested, in fact, that they would become the second leading cause of the burden of disease in low-income countries, the third highest cost in lower middle-income countries, and the highest cause in upper middle-income countries. The projections also suggested, in fact, that unipolar depressive disorders alone by 2030 could constitute over 8% of the burden of disease in the high-income countries. When we think about who's affected, it's important to understand that people throughout the world are affected by the 4 mental disorders we're discussing. Often such disorders begin, as I mentioned, in adolescence or during the young adult years, but they can begin later in adulthood as well. Now, it's also exceptionally important to understand that many people throughout the world suffer from a mental disorder that has not been diagnosed. This may be due to a lack of knowledge, it may be due to a lack of services, and it might also be due to a lack of stigma associated with such disorders. It's also true, of course, that in many places people lack the economic means to pay for health services, and this can also prevent them from seeking such services. Generally, we should expect people who are better educated and have higher socioeconomic standing to be able to seek and navigate mental health services better than people who have less education and less income. We should also note that in many settings, people seek care for these disorders from a range of traditional healers, partly because they understand them, perhaps they're also more accessible, but in some places they seek them because they also believe that these disorders are spiritual in their origin. There appear to be both genetic and non-genetic risk factors for mental disorders. It's clear that women suffer, as we said, from depression more than men. Early childhood abuse, violence, and poverty may be important environmental risk factors for depression. However, there's still very little definitive evidence on the risk factors for schizophrenia, bipolar disorder, or panic disorders. We do know, however, that there's an important relationship between a range of social determinants and mental disorders. Poverty, low socioeconomic status, low levels of education, and low levels of social support increase the risks of these disorders. If people succumb to them, in fact, they face additional risks of falling into lower productivity, losing some of their income, and continuing a downward vicious cycle where they get sick, they can't work, they get poorer, and they feel less well. There are relatively few data on the costs of these disorders. In addition, the studies that have been done largely on high-income countries. Nonetheless, these studies are indicative of the large direct and indirect costs that all countries face from the very large burden of these disorders. A study done in the United States, for example, suggested that mental health disorders cost the U.S. about 2.5% of its national income every year. Similar studies done in Europe have suggested that these disorders cost these European countries between 3 and 4% of their national income every year. In addition, when we look at the costs to individuals and to the groups with which they work, for example, studies done both in the US and in the United Kingdom have shown that workers suffering from depression lose 40 to 45 days of work in a year as a result of their illness. Now, some mental health disorders can be prevented, and some can also be treated effectively. But unfortunately, despite the enormous importance of mental disorders, there's often an inadequate understanding of the importance of mental health, a lack of funds for mental health, a shortage of personnel who understand mental health, and as I mentioned, an enormous amount of stigma surrounding mental health disorders. As a result, there's been very little progress in most low-income countries, and in some middle-income countries as well, in addressing these problems. Even many high-income countries fail to pay sufficient attention to or engage in best practice diagnosis and treatment for people suffering from such disorders. Given the important burden of disease associated with mental disorders and the low level of development of mental health services in many countries, the World Health Organization recommends that countries take a number of at least fundamental steps to lay a foundation for addressing mental health issues. And these include having a mental health policy, ensuring there's a unit of government responsible for mental health, budgeting for mental health programs, including program development, training, drug procurement, and program monitoring, training primary health care workers in mental health, and integrating mental health into primary health care programs. In addition, the World Health Organization has recommended, as a part of its Mental Health Gap Action Program, that a package of mental health interventions should be available in each country, tailored to the burden of disease, tailored to the mental health resources available, the financing available, and the local context. And we'll see this in the next graphic, where they've recommended that countries address childhood mental disorders by preventing such disorders as far as possible, partly through better maternal nutrition and care, treating children pharmacologically with drugs as appropriate, and also offering them psychosocial support, addressing depression by treating with antidepressant medicines and providing psychosocial support, and addressing schizophrenia and other psychotic disorders by treating with antipsychotic medicines and enabling family and community-based psychosocial support as well. Very recently, the Disease Control Priorities Project for Developing Countries, generally known as DCP3, the third edition of this work, has issued a very important volume on mental health that I would encourage you to look at. And DCP3 has suggested, for example, a number of platforms, including schools and healthcare services, through which countries might seek to better, more effectively, and efficiently address mental health. DCP3 has suggested, for example, that in schools, schools offer life skills training to build social and emotional competencies for children. And along the lines of this, DCP3 has also suggested that healthcare services should offer diagnosis and management of depression and anxiety and continuing care for schizophrenia and bipolar disorder in primary care. Now, related to these efforts, a number of public health measures can be taken to address some of the risk factors associated with mental disorders. Addressing maternal depression can reduce mental health disorders in children. Reducing abuse of women and children can reduce the burden of mental illness among the abused. Curtailing bullying of students in schools is also very important. Improving parenting skills is helpful to the healthy development of children. Appropriate care and counseling for children and adults affected by war, conflict, and other complex emergencies can also reduce the risks of mental illness. A significant amount of the mental health care, traditionally in many low and middle income countries, has been offered in large psychiatric hospitals that have consumed an overwhelming portion of the country's budget for mental health care services. However, evidence is growing that for $2 to $4 per person per year, countries can provide effective and efficient services that are community-based and that would offer drug therapy combined with psychosocial support for bipolar disorder, depression, and schizophrenia, and drug therapy for panic disorder. The goal would be to integrate such support into routine primary health care services as far as possible. And a very recent study that has emerged has suggested that the benefit-cost ratio of investing in these services is exceptionally high. In fact, the ratio for the treatment of depression and anxiety was between 3.3 to 1 and 5.7 to 1. In other words, every dollar invested in such services yielded, in some cases, almost $6 in return. Given the weak state of health systems in most low-income and many middle-income countries, and their lack of attention to mental health, accomplishing these aims will require much greater political attention to mental disorders. In addition, it's going to require measures to get additional funds for mental health and wiser use of them as well by taking some of the measures that we've discussed. There have been few mental health success stories in low and middle-income countries. However, there's been some important progress in Uganda in creating a community-based approach to mental health. More recently, there's been some very exciting evidence of successful outcomes achieved in cost-effective ways through community-based approaches to mental health in parts of India. And in addition, although Chile is now considered a high-income country, it will be important to follow the progress that Chile is said to be making as well. It's also essential to keep in mind as one seeks to address mental health issues in low and middle income countries that these countries have scarce financial resources and a very limited number of mental health professionals. Thus, they are very unlikely to be able to take an approach that's based on psychiatrists and psychiatric nurses, as might be the case, for example, in high-income countries. Rather, approaches that are scalable, effective, and sustainable will almost certainly in low and many middle-income countries have to depend for some time to come on community and family-based approaches similar to those that are now being used in India, as I mentioned. Now, putting such an approach in place will require that countries take a number of steps. They'll need to shift financial resources from the large mental hospitals to community-based approaches to diagnosis and treatment. They'll need to train primary care physicians and other staff working in primary care to treat the mentally ill. They'll need to circulate to health workers protocols for brief behavioral and cognitive therapies so at the lower parts of the system, community health workers and primary health workers can make effective and efficient efforts in addressing mental health, and they need to increase the availability of modern generic drugs. Mental health, as I mentioned, takes an enormous burden on the health of people in all countries. The burden of mental health conditions is generally underappreciated, underfinanced, and highly stigmatized. And yet we know there are a number of measures that can be taken, and we're learning more and more about them all the time, to address these disorders in ways that appear to be doable, scalable, and cost-effective. It's almost certainly time now for a larger range of countries, especially those that are low-income and lower middle-income countries, to pay increasing amounts of attention to mental disorders, their exceptional burden, the toll they take on people, communities, and society, and begin to take more and more of these measures to address them. In the next session, we're going to speak about injuries.